All right, re-recording because the first one was 10 minutes. So, patient case A. Differential diagnoses could be vestibular migraines or PPPD. Vestibular migraines because of some predisposing factors like being a female, having unilateral symptoms even though they're auditory and not headache as they would be for vestibular migraines. Aggravated by physical activity, the walking, the running, lasting anywhere from 4 to 72 hours. Having just dizziness, vertigo at all. It's the second most common cause of dizziness or vertigo, and is the most common neurologic cause of vertigo in adults, of which she is. PPDD because feeling like she's off balance and having no episodes of vertigo during those feelings of off balance. She has had episodes of vertigo prior, and she also says it feels like the whole world is bouncing during walking and running. The most likely vestibular diagnosis is Meniere's disease, criteria being 2 or more spontaneous episodes of vertigo lasting 20 minutes to 12 hours. She has had 4 past episodes of vertigo lasting for several hours, so that fits there. Documented sensorineural hearing loss in one ear and at least one instance prior, during, or after vertigo episodes. So she reported hearing the right ear is not as sharp and had documented sensorineural hearing loss in that same ear, which is since improved back to normal, so she checks that box too. And she also has the fluctuating oral symptoms in the affected ear, the ringing, the tinnitus during the vertigo episodes. Test results, spontaneous and gaze hook nystagmus are normal. VOR was abnormal, and that just means that it's something's wrong. It doesn't distinguish central peripheral. Hit towards the right with the corrected saccadic movement indicates that is peripheral involvement. Left side is normal, and again that's going towards the affected side, so the right side on that one. Dynamic visual acuity test, abnormal results, but again doesn't indicate central peripheral. The Dix-Hallpike world test, normal. Modified CAT SIB, condition 4, only 1 second. That system or that condition is testing the vestibular system, and that low of a score indicates that something is not working properly in that system. Sharpen-Romberg with eyes closed, only 10 seconds with excessive sway, again further suggesting the vestibular system is not working as intended. As far as the outcome measure goes, FGA, hers is a 19, cutoff score is 22, so she's a fall risk. The DHI, 52%, puts her in the moderate category, being 31 to 60. The ABC of 75 has a cutoff score of 67% or below, so on that one she's not a fall risk. The TUG's time of 18 seconds. The cutoff score for vestibular patients in the TUG is 11.1, so on that one she's considered a fall risk. 10-meter walk test, time of 0.92 meters per second. Speed, sorry. So the normative time for her age and sex is 1.313 meters per second, with the cutoff score being less than 0.7. So her 0.92 puts her between the cutoff and the age and gender norms, so she is slower than expected but not a fall risk, according to that one. So for the treatment plans, the first thing would be to educate them on what their condition is, what it means, and kind of what lifestyle modifications might benefit them. So improving sleep, decreasing stress, avoiding diuretics like caffeine, alcohol, or even tobacco, reducing sodium intake as well. Those will help reduce frequency and severity of the symptoms, so that's always should be step 1 for this condition. And then after that, you can treat the symptoms as if they were unilateral vestibular hypofunction or loss, because of her reported feelings of off balance. So you would do gaze stabilization because of those world bouncing, jumping around and moving symptoms, and habituation exercises for the dizziness from vertigo. And if those hearing symptoms return, you can refer back to PCP for medications like diuretics, and if those don't work, corticosteroids, audiologist, or ear, nose, throat doctor. As far as the actual interventions goes, step 1, you do not want to treat during an acute attack, so no treatment there. And step 2 is to use a gaze stabilizer. So you need something to look at, like a business card or a playing card even. You're going to look at the object. So the Jack of Hearts is a little kind of busy. You kind of want something simple to look at, so something better would be like a Ace of Clubs. And with that one, you can just look at that center pit. So hold it at arm's length, and then you want to maintain that gaze on that center pip. So you can go left to right, you go up, down, That would be good for her because when the running and walking, that movement is up down, so that would help with her symptoms. And ways to progress that would be to start in sitting and then progress. You can go into standing, narrow base of support, uneven surface to stand on, or even while walking, which is ultimately the goal for her because that's where her symptoms are produced. As far as the next one goes, habituation, dosing. You want to do at least 2 minutes a session with 3 to 5 sessions per day. Some symptom flare-ups are expected, and that's normal. You just don't want them to be severe, so kind of mild to moderate. And the next one for habituation, it's going to be kind of similar, except the difference is there's no object to focus on with the gaze, so it's just going to be going head, left to right. There are different movements to choose from, but I think the 3 most prevalent for her would be the head side to side, head up down, and then in standing, turning 180 degrees to the left or to the right. And with that one, you want to do those movements until you start to provoke those symptoms into that mild to moderate range. Do that 3 to 5 times, 2 to 3 times a day. And same type of progression, start in sitting, minus the standing one that you're returning, into standing and standing on uneven surface, eyes closed, and then introducing some walking too, again, because that's where her symptoms are coming from. So, and if they become too much, she can rest and then add 30 seconds and then start the next, or continue that exercise, that repetition, or wherever she's at in the progression. It's okay to resume once the symptoms reside to finish the exercise. Thanks again for great 2 years. No, thanks for PT school. Yeah.